Good afternoon, everyone. Welcome to our National Public Health Week event, today focusing on an interdisciplinary discussion on solution to Brooklyn's maternal health crisis. This is an event that is co-sponsored by the SUNY Downstate Health Sciences University School of Public Health, as well as the Brooklyn Borough President's Office of Antonio Reynoso, who will be joining us shortly. The run of show today will begin with a brief presentation on the current state of the maternal health crisis in New York City, with a presentation of the most recent data that is available to us. And then we'll have Mr. Reynoso give his keynote speaker speech. And then we'll move into a moderated discussion with our dynamic and distinguished interdisciplinary panel. I will give bios and introductions at that point, but before we begin, I wanted to present the data and the current epidemiology of the New York City maternal health crisis. I just want to acknowledge that this talk is not designed to be a scientific or academic talk, but because we're talking about solutions, I think it's important as a public health researcher and for people who are designing policies and interventions to address this crisis. It's important for us to understand the data and the causes of what we've been hearing about, for the last, I would say, decade, about the maternal health crisis, not only in New York City, but in the United States. Okay, I want to acknowledge all my speakers here. And as I said, after the presentation, I will give more specific introductions of each panelist. So the panelists are listed here, and I'll begin my presentation. Okay, so as I said, I don't want this to be an academic talk, but I think we need to understand the data, because sometimes the data that's presented out there to the public can be confusing. So I'm trying to keep this brief. I'm emphasizing 9 different points, and the points that I'm going to emphasize will hopefully be able to frame the conversation that we're going to have subsequently. Okay, the first point that I want to point out is that compared to its affluent peers, US leads leads the world in maternal mortality rates. And so many of you might have seen this before, but if we compare the United States to other countries that have similar income levels, for example, and perhaps in particular in Europe, US rates of maternal mortality have been soaring. As you see here, in every other country listed here, the rates are declining. But from 2000 to 2015, the rates of maternal mortality in the US have been increasing, and they continue at that pace, even post 2015. Second, it's important to understand that the timing of a pregnancy-related death is important. Okay, so what we see here when we hear about maternal mortality, when we hear about pregnancy-related mortality or pregnancy-related death, that death can occur at multiple time points during the pregnancy. So we have here sort of the latest data on how deaths are distributed by timing of pregnancy. 31% occurred during pregnancy, 17% occurred during the actual day of the delivery, 19% occur 1 to 6 days postpartum, 21% occurs 7 to 42 days postpartum, and 12% occur between 43 and 365 days postpartum. So I circled the times that range from pregnancy to up to 42 days, because these are typically the time periods that we refer to when we talk about a maternal death. Pregnancy-related mortality relates to a death during pregnancy that occurs during pregnancy up to the first year postpartum. So we have to be mindful that, again, when we look at the data, we have to be careful of what kind of statistic they're talking about and what time during pregnancy does that relate, death relate to. In addition, it's important to understand the timing of the death because the causes of the death will vary according to at what the time point in pregnancy it occurs. So it's important not only to understand the data, but it's important because the timing of the death will also determine sort of what the cause of death would be. Okay, third. So we saw in the first slide that the US, compared to other affluent nations, has the highest rates of maternal mortality. But what we don't really talk about in the global space in terms of why it's so high is that, the rates in the US are really driven by the rates among Black women. So, and again, we all know, in the US, we all talk about the race disparity. So this is not probably surprising to many of us. I'm sorry, this is not very surprising to many of us. But here we see data from the CDC's maternal mortality surveillance system and program. And here we're referring to pregnancy-related deaths. We see that there is a wide disparity in pregnancy-related death between Black and white women. And we also see that the problem is pronounced in women that are over the age of 35. So if we actually look at the rates among women over 40 and over, Black women have a rate almost 5 times higher than the rate among white women. Maternal mortality rates also vary by race and Hispanic origin. This is, so I presented a little bit earlier data that the CDC released, but this is also just, I wanted to acknowledge that there is also some later data that came out. This is based on the latest data on maternal mortality, which is, I believe, 2019. And we see here, that the rates are still pretty high among non-Hispanic Black women and remain almost 3 times higher than the rate among white women. My fourth point is that the Black-white disparity in pregnancy-related death in New York City in 2019 is 5-to-1. So it's slightly pronounced. The Black-white gap in maternal mortality or pregnancy-related death is pronounced in New York City. Compared to 3-to-1, it is 5-to-1. And I want to just remind us that I'm referring to pregnancy-related death, which is a death of a woman during pregnancy or within 1 year from the end of pregnancy that is due to a pregnancy complication, a chain of events initiated by pregnancy, or the aggravation of an unrelated condition by the physiological effects of pregnancy. So this is a pregnancy-related death. Again, I know some of us have heard that the disparity is 8-to-1. I don't want to complicate things, but we could talk about that in the discussion later on. That's actually referring to pregnancy-associated death. So this disparity here is the latest data that we have from New York City, and the pregnancy-related death, the disparity in pregnancy-related death is 5-to-1 between comparing Black to white women. My fifth point is that Black-white disparity and severe maternal morbidity in New York City follows the same pattern. So from a population health standpoint, researchers tend to look at or examine severe maternal morbidity because it's a more frequent event. It's very difficult to study a maternal death because it's so rare. But severe maternal morbidity is 100 times more frequent than a maternal death, but is also considered a near miss. And severe maternal morbidity is a life-threatening complication of labor and delivery that result in significant short and long-term consequences to a woman's health, such as heavy bleeding, blood clots, serious infection, or kidney failure. So we tend to focus on severe maternal morbidity, which again approximates a maternal death and is considered a near miss. This slide presents to us the severe maternal morbidity rates by race and ethnicity in New York City. In 2018, we see here, this is the latest data on severe maternal morbidity, and it's published by the New York State Health Foundation, and it's based on not only death certificates, but also claims data through the New York State Sparks data system. So we see here that rates among Black women in New York City are increasing, severe maternal morbidity rates, and the disparity obviously remains and is pronounced as well. So if we compare Black to white women, the rate of severe maternal morbidity is 2.3 times higher than the rate of severe maternal morbidity among white women. And then now so we've gone from the United States to the New York City. Now we're focusing specifically on our borough. And one of the epicenters of New York City's maternal health crisis is here in central Brooklyn. This is the latest data that we have on severe maternal morbidity that breaks up the rates according to neighborhood. And so I just want to acknowledge that the data is somewhat dated, but it's the latest data that we have based on this aggregation. Okay, so in central Brooklyn, we see here we have bar graphs representing the rates of severe maternal morbidity in the years 2008 to 2012 versus 2013 to 2014. And we see here that 3 neighborhoods in central Brooklyn, specifically Brownsville, East New York, and East Flatbush, have rates that far exceed both the US average, the New York City average, and I also have another comparison point here. So Upper East Side, if you want to contrast it to a very affluent white neighborhood, the disparity is quite wide between central Brooklyn and Upper East Side. I also want to note here that there has in East Flatbush specifically, where SUNY Downstate is located, the rate of severe maternal morbidity between these 2 periods actually increased by 40%. So that's something that needs further study. Black women originating from the Caribbean have the highest severe maternal morbidity rates in New York City. And we know that Black women from the Caribbean are concentrated in central Brooklyn. Again, and then here, this is the data source is the same data source that was reported in the previous slide, and also based on that, that time period. We see that the rate of severe maternal morbidity varies by country of birth, with women originating from Haiti having the highest rate of severe maternal morbidity in all of New York City. And again, as a comparison to provide perspective, I also provide the rate of severe maternal morbidity in the United States as well as in New York City. And we see here that the rate among Haitian origin women obviously far exceeds the rates of the rate in the compared to the national average in the United States, as well as the aggregate average in New York City. Yes, so we have a Q&A question. These slides will be recorded, and I can share with them. I can share the slides with anyone who wants to send me a request. And then my 8th point, I'm almost there. I'm almost towards the end. My 8th point here is that in New York City, although we saw in the previous slides that Haitian origin women and Black women who originate from the Caribbean have the highest rates, the actual that's different than the actual burden in terms of numbers, because the burden of severe maternal morbidity varies depending on how large that population is in New York City, right? So In New York City, the severe maternal morbidity burden is highest in women of Latin American origin in terms of overall number. Okay, so here we see that, again, using the other data source, and I apologize, I never know where to place my Zoom. Oh, sorry. I never know where to place my thumbnails for the images because they get in the way of the titles. Okay, so here we see the burden among immigrant women and the actual number of cases of severe maternal morbid events by country of origin. And then, I want to be able to acknowledge that it is a complex condition and it affects different populations differently. So here we see that women who originate from Mexico and the Dominican Republic actually have the highest burden of a severe maternal morbid event in New York City. So in terms of numbers, they contribute the largest number of severe maternal morbid events in New York City. But if we look at rates, Haitian origin and Black Caribbean origin women have the highest rates. And then finally, I want to end with a statement about what are the causes of what all the deaths and the morbidity that we were just presented with. And I want to conclude that the causes are multifactorial, but recent data suggests that the increase in mortality does reflect the US's chronic disease epidemic. Cardiovascular disease and hypertension are major contributors to pregnancy-related death at every stage. Okay, here we see that during pregnancy, so sorry, I can't. Simia, can you move? So here we see the cause of death by timing of pregnancy. The top panel is during pregnancy, then we have day of delivery, 1 to 6 days postpartum, 7 to 42 days postpartum, and then 43 to 365 days postpartum. And we see that during every time point, cardiovascular disease is a major contributor of cause of death during every time point. So this only lists the top 3 causes of death during pregnancy, but the causes are, as I said, multifactorial, heterogeneous, but I'm only listing here the top 3 causes. Oh, and then, okay, and then finally we have, I will take questions after this. Finally, we see here, just wanted to be able to compare what's going on in New York City versus what's going on nationally. And here in New York City, we see the same trend. Interestingly, we do see in this graph that the causes due to cardiovascular problems have been increasing over time. So what this graph shows us are the causes of pregnancy-related death from 2001 to 2015. And we see here that CVD is becoming increasingly a major contributor of pregnancy-related death in New York City. Pregnancy-induced hypertension, there seems to be a decrease. And I think also I want to bring people's attention to this point where in the past, hemorrhaging was a major contributor of severe maternal morbidity as well as death, but we've done a really great job at reducing that over the years. And there has been a decline in hemorrhage as a cause of death over time. Okay, so let me just. Yes, no, I agree with Ms. Hall. Okay. So I'm going to end the data portion of this presentation. And again, this is not an end to the discussion because we're going to move into a discussion about the data, as well as what are the experiences of our panelists in terms of what they see as they are on the front line dealing with this crisis. Before beginning and entering the discussion, I'd like to thank you. I wanted to make sure that I acknowledge everybody involved in the organization of this, and I will introduce the panelists subsequently. So do we have Mr. Reynoso here? Oh, yes, we do. Yes. I see. I can't see. I'm sorry. Samia, can you, I have a hard time. I'm going to exit out of this. Okay, there we go. Okay, great. Well, hi, Mr. Reynoso. So I'm going to introduce the panelists and our keynote speakers here. I didn't see you before because of the way my screen was organized, but I'm glad to see that you're here, and so I'm ready to introduce and begin our moderated discussion. Mr. Antonio Reynoso is obviously our newly elected Brooklyn Borough President. He is the first Latino Brooklyn Borough President and is a native Brooklynite. In 2009, he joined the City Council and demonstrated his commitment to advocating for the residents he represented and the thousands more throughout the city with similar needs. He focused his energy on quality of life issues, including waste management, policing, tenant safety, transportation, and land use, where he took the lead in advocating and rezoning of Bushwick, Brooklyn. Now, Mr. Reynoso is serving Brooklyn to make the borough the progressive capital of the world by building on his extensive record in the City Council. Reynoso's twin guiding principles throughout his life have always been the concepts of justice and equity, and he has vowed to fight each and every day to give Brooklynites the opportunity to thrive and succeed. He has also made maternal health a priority of his agenda. So please welcome Mr. Antonio Reynoso.
Thank you. Thank you all so much, Amy. Thank you so much. Amy, you keep saying it's not a scientific presentation, but it is. What it isn't is a lecture. You want to make it into a conversation, but the information you're giving us is scientific in nature and is true.
It is. I appreciate that, but I don't like, because again, we're here about solutions. In order for us to come up with the solutions, we have to sort of know the data and the science. So I appreciate that point.
Agreed 100%, 100%. So I just want to thank you, Amy, for your introduction, and everyone that's on the call, including my mentor in this work, Ms. Helena Grant, who introduced me to this in a more professional way, I guess I would say. A lot of us know that this is a problem, but few know how bad the problem is, and few do anything to solve for the problem. So being introduced to Ms. Grant, who caught my wife's baby, or our baby, it has really put me on a path to wanting to be one of the premier advocates in ending maternal mortality here in the city and in this country and in the world. So I'm going to proceed with my statement. Again, I am Brooklyn Borough President Antonio Reynoso, and I'm grateful to SUNY Downstate for convening our discussion today around one of, if not the most important conversations we must be having: maternal mortality. Black pregnant people in New York City die at 9.4 times the rate due to childbirth complications than their white counterparts. I wasn't fully aware of this stark disparity until my wife, Ileana, was pregnant with our first child. To imagine that my wife was more likely to lose her life during or after childbirth was terrifying to me. And I then knew that I had to play my role in helping to close the disparities. Many factors contribute to these disparities. Studies show that doctors are less likely to listen to Black mothers due to implicit bias. Behavioral health conditions are the top cause of pregnancy-associated deaths, specifically from postpartum overdose and suicide. Social determinants of health, such as lack of access to healthy food and safe and healthy housing, overexposure to harmful environmental conditions, and chronic stress are major factors. And the conditions at our hospitals and the resources they have to dedicate to this issue make a meaningful difference. My wife and I say that her experience during childbirth was positive and safe because of one main reason: being treated at New York City Health and Hospitals Woodhull for both of her pregnancies. My wife had access to excellent midwifery care. Midwifery services promote a shared decision-making model for birthing care and decrease unnecessary medical intervention of people in labor. Having that additional emotional and physical support makes a difference. This can lead to decreased cesarean rates, decreased maternal mortality and morbidity, and increased client satisfaction. It's true, we were lucky to have midwifery services, and today my wife is healthy and we have 2 happy and thriving sons, Alejandro, who is 4, and Andres, who is 1. But we can't rely on luck to keep our pregnant and birthing loved ones safe. My family's experience with childbirth and my education around associated disparities has led me to make my top priority as Brooklyn Borough President to end maternal mortality and morbidity. In my new position, I'm working with Brooklyn hospitals to upgrade birthing facilities through capital proposals. If fully funded, the capital upgrades would allow select hospitals to utilize state-of-the-art technology to improve patient safety, expand birthing options, provide new opportunities for patient education, improve continuity of care, and prioritize privacy and infection control. But tackling this issue goes beyond capital investments. As my advisors on this issue, some of which are on today's panel, have made clear to me, improving facilities only goes so far. We must also improve the practices that take place in those facilities and support outpatient services, including social services and community care models that address underlying issues facing people of color. For example, New York City H&H has made many investments in their maternal health capabilities and offerings, including the system's maternal medical home and obstetric simulation trainings. The maternal medical home program provides referrals and services to help address many of these issues I mentioned before, particularly behavioral health and socioeconomic challenges. The simulation trainings help practitioners learn to identify and address the major contributors to mortality and morbidity during the birthing process. I'm also looking forward to supporting policy that would increase health insurance access for all birthing people, such as the length of coverage and insurance classifications that can limit care. In addition, I intend to work with partners to support the midwifery pipeline, ensuring these healthcare workers are culturally competent and increase access to the same type of care my wife received. Mayor Adams 2 weeks ago announced increased midwifery and doula services throughout the city with the help of our New York City Department of Health and Mental Hygiene. Yes, there's attention on this topic right now, and a lot is being done through the collaboration of many partners, experts, elected officials, and advocates. But we must not lose this energy. I look forward to listening to today's panel's discussion from our maternal health and women's services experts at SUNY Downstate, New York City Health and Hospitals, Life of Hope, and the Caribbean Women's Health Association. Partners who are on the ground doing the work. They've allowed us to sit at the table as we make pregnancy and childbirth healthier and safer for our loved ones, community members, and patients. I want to thank you all for giving me the space to be here. And please know that I'm like a vessel to be used to push these issues. And I'm grateful to even be here with you all. Don't forget to spread love. It's the Brooklyn way, and love you all.
Thank you, Mr. Reynoso. You know, we want to also share the we welcome you to our panel, and I feel very honored and excited to be hosting this distinguished and I would say dynamic panel, because everyone here is on the front lines, right? And we all have a dedication to equity, not just health equity, because we all know that the social determinants of health, are the most challenging ones to change. And you mentioned a lot of them, Mr. Reynoso, in your keynote. So I appreciate that you appreciate it and you acknowledge that, because it is the most challenging, the biggest challenges that we have, in public health at this point. So, well, thank you so much, Mr. Reynoso. And now we'll move into our moderated discussion. And I am, as I said, very pleased and excited to present to you our distinguished and dynamic panel. They all work on the front lines. Mr. Reynoso has already mentioned, a lot of the work that they're doing. So I'll begin with introducing Ms. Helena Grant. Helena Grant has been a practicing midwife in the Borough of Brooklyn for 25 years and is the director of midwifery at the New York City Health and Hospitals Woodhull and co-chair of the corporation's Midwifery Council. She is also immediate past co-chair of the New York City Department of Health and Mental Health's Maternal, Mortality, and Morbidity Committee. She is currently the acting president of New York State Midwives Vice Chair of the Black Caucus for the American College of Nurse Midwives, and co-chair of Brooklyn Borough President Antonio Reynoso's task force to end maternal mortality and morbidity. That's why you're so busy, Ms. Grant. I mean, that's why you're always so exhausted. You have too much going on. Anyway, so I look forward to hearing Ms. Grant's insight and everything that she has to share about her experiences with us. Thanks, Ms. Grant. And our next panelist is Ms. Cheryl Hall, representing the Caribbean Women's Health Association. Since its inception in 1987, Caribbean Women's Health Association has made reducing infant mortality in the communities we serve as one of its highest priorities. As the executive director, Ms. Hall has been involved in Healthy Women's Health Futures, a citywide project since 2014 to provide health services to women and families across New York City, preconception, interconception, and doula care services. Their role has been expanded to serve Manhattan, Bronx, and Queens. And most recently, they were awarded one of the citywide doula initiative grants to serve all boroughs of New York City. Impressive. Welcome, Ms. Grant. And then we have, oh, good, we have Dr. Wendy Wilcox. Dr. Wendy Wilcox, I'm sure everybody here already knows who she is. I was a little afraid she wasn't going to show up, but she's here. Dr. Wilcox is the Chief Women's Health Officer for the New York City Health and Hospitals and has been a board-certified obstetrician gynecologist for over 20 years. Throughout her career, Dr. Wilcox has taught medical students and residents, participated in research activities, and advocated for equitable health care for women and their families, especially Black, Indigenous people of color and families. As co-chair of the New York State Task Force on Maternal Mortality and Disparate Racial Outcomes, co-chair of the Brooklyn Maternal Mortality Task Force, as well as in prior roles, Dr. Wilcox has informed national and local efforts to decrease Black maternal mortality and severe maternal morbidity. Welcome, Dr. Wilcox. And then I have here Dr. Christina Pardo, who is a close colleague of mine. Dr. Christina Pardo is a physician and community advocate who is currently the Director of Health Equity and Vice Chair of Quality and Innovation in the Department of Obstetrics and Gynecology at SUNY Downstate Health Sciences University. She completed her undergraduate education at Howard, followed by Rutgers Robert Wood Johnson Medical School, and completed a master's in public health in international health at Boston University. She returned to New York for obstetrics and gynecology resident program at SUNY Downstate. Following residency training, she joined the faculty at Stony Brook University, where she co-founded the Global Women's Health Program. Her interests are in health inequities and community engagement and development led her to the SUNY Downstate Health Sciences University, where she started a new division of health equity. Her work centers on community academic partnerships to address health equity, as well as integration of innovative community-led initiatives for quality improvement. She is also the Deputy Director of Life of Hope, a community-based organization where she focuses on culturally informed interventions to improve care for immigrant communities. And shout out to Life of Hope. I hope they're in the panel. We'll probably hear, I hope they're in the audience. We'll probably hear from them later. And then finally, last but not least, Dr. Tanya Blackwell, Dr. Blackwell, who will be our discussant, and we'll hear from her later on. Dr. Blackwell completed her undergraduate studies in chemistry and received her DRPH from SUNY Downstate School of Public Health. She's an environmental scientist who is focused on environmental and occupational health hazards. Her research shifted to understanding the effects of toxic exposures on health, with particular focus on disparities in maternal and child health. She serves as the Director of Community Engagement and Research for the Arthur Ashe Institute for Urban Health, where she focuses on community health empowerment and equity. Please welcome Dr. Blackwell. Okay, so I will begin with our discussion. And for those who are submitting questions in the Q&A, we will get to your questions. There will be a 15-minute session dedicated to Q&A from the audience. Okay, so I'd like to begin sort of reflecting on, and Dr. Wilcox, you weren't here, but I already sent you the slides, but reflecting on some of the data that was presented earlier on and some of the recent data trends. I want to acknowledge, well, Ms. Hall mentioned something about one of the slides not being updated, but all the data that I present is the latest data that I've that I know to be available. So I want to acknowledge that if it isn't updated, I don't know that it's available, but if you know of a more updated source, please let me know. So for the clinicians in the panel, can you comment on the recent trends? New York City data suggests that the causes of deaths are unstable, but there's an increasing trend towards CVD, cardiovascular disease, as a cause for death. From your experiences as physicians or midwives caring for the population, is this data consistent with what you are seeing? What contributors, or as we say, downstream determinants of health should we be focusing on today to prevent a severe maternal morbid event or a maternal death? And do hospitals have the capacity to address these? So, so I'd like to begin with perhaps Dr. Porter or Dr. Wilcox. Dr. Wilcox?
Thank you so much. I'm here. Can you hear me?
Yes, we do. Thank you.
Yes, thank you so much. And I appreciate being a part of this panel and talking about, as you know, this really important topic. And I've been involved in this space for a while. One thing I would like to call attention to is the slide on severe maternal morbidity. And I believe that was, are you able to put it back up or?
Yes, I'll put it back up. Hold on. Which slide was it? Hold on.
So, it was SMM burden among
Hold on. Yes, I am.
women.
Is it move forward?
Central Brooklyn. At any rate, yes.
Okay.
So, you know, yes, it is the highest. You had another one though, I think, where you were showing that it's right now twice as high in African American or Black women. Yes. So am I correct in saying twice as high from your 2017, 2018 data?
So here, yes. Oh, right here. So this is, yes. So this is data published by New York State Health Foundation.
Right.
And based on Sparks. Yeah, go ahead.
Right. And you said, so it's 2.3 per, I really want to call attention to that because that really shows the work that has been done around this space by all who are involved. When the initial study was published on SMM in New York City, 2013 to 2014, it was 3 times as high. So to bring it down by a factor of almost 1, obviously we cannot sit on our laurels and we must continue to do the work around this space. But really to bring it down by almost a factor of 1 really has to be acknowledged. And we are improving and we need to go further, but let's also pause and acknowledge the improvement. When we look at our causes of death, and thank you so much, Amy, for getting updated data and showing that we really have to focus as a society on cardiovascular disease. But you know what else we need to focus on? Infection. So this is really, it is unfortunately a common of what happens, but as we pay attention to and focus on the top causes, as we have done. So as you know, probably from about 10 years ago, there were multiple initiatives from the state, from New York City, from our professional organizations, and we were focusing on the top 3 causes of maternal death and of severe maternal morbidity. And those were hypertension, hemorrhage, and thromboembolism, which is a blood clot. So it travels, from a DVT from your leg into your lungs. And we focused on those. And yes, it has taken almost a decade to address, but those rates have fallen. And now we see we have new needs to address. So we absolutely need to look at sepsis, because sepsis kills people. And so the Sepsis Foundation, as well as AIM, Alliance, AIM, I'm trying to, I'm sorry, I'm forgetting the acronym right now, but AIM, as well as CMQCC, the California Maternal Mortality Collaborative, and ACOG are now looking at sepsis and cardiovascular disease, and will soon be coming out with bundles to address those. But we also know that when we only address things in the clinical space, it doesn't solve the problem, right? We have persistent disparities, and while the entire number comes down, we know that we will still have the disparity with BIPOC people. And so that's why we focus in other areas of pregnancy-associated causes of death. Now, I just want you to know that mental health is actually pregnancy-related. And mental health, I think, while it's not covered on this slide, is in the other category. And there was a recent CDC publication that said that mental health and substance abuse are unfortunately rising and becoming top causes of morbidity and mortality as well. So, we will move to new areas of focus, and we have to keep in mind the clinical factors, which are, sepsis/infection and cardiovascular disease, as well as, because now, unfortunately, those other causes, those non-clinical conditions, mental health, substance use, and of course, unfortunately, as we've sometimes seen in the news, the homicides and the suicides are also becoming really large factors. I'll stop there.
Thank you, Dr. Wilcox. Can you just elaborate a little bit more? You mentioned that mental health is pregnancy associated, or it's pregnancy associated?
It's actually pregnancy related.
Pregnancy related.
I think what's happening, and it should happen, as we mature in looking at our data, and unfortunately in examining some of the terrible circumstances that surround some of these deaths, and as we've pushed out the definition from 42 days, which it used to be, to really looking at a full year within the end of a pregnancy, then we get to see all the other factors, and we have a widening lens. And so as our maternal mortality review groups across the country have become more mature, mental health conditions are really being seen as exacerbated by pregnancy and becoming much more pregnancy related.
And then for the audience, because again, there are nuances between pregnancy related and pregnancy associated. Can you just comment briefly on what are the major differences?
Sure. Pregnancy, I'll start with the larger bucket. So any death within a year of the end of a pregnancy of any length. So it could be an ectopic pregnancy. It could be from even from an abortion. So those would be at the very early end, to, within a year of the end of a normal full-term delivery, are considered pregnancy associated. And then you have a subset of those cases, which we call pregnancy related. And those tend to be deaths that we think are causally related to the pregnancy. And so as we get more information about mental health conditions and how really mental health, pregnancy is a stressful time and can exacerbate many underlying conditions, including behavioral health condition, then that's why you would find behavioral health conditions under pregnancy related as opposed to just pregnancy associated. And
excellent, thank you.
It's a decision point. Sometimes as we're examining different situations, we will have to make a decision on whether or not it is causal to the pregnancy or not.
Yes, and you are in the position to help with that, correct? With your role on the New York City maternal mortality.
Actually, I'm not on the M3RC anymore. I'm not on the New York City committee, but I am on New York State's Maternal Mortality Review Board.
Okay, great. Thank you. That's excellent. And I want to give the floor to Dr. Pardo or Ms. Grant, because Ms. Grant has educated me, because we had met prior to this, that she is in the hospital working directly as a midwife with these women. So do you want to add to what Dr. Wilcox shared with us?
Good afternoon, and thank you for having me. I want to add to some of the statistics as well. I just wanted to say, if you could go back to slide 5.
Sure, I'm just, for some reason, having technical difficulties. I'm going to go back to slide 5. Hold on. Right.
I'm just going to keep talking while you get that.
Yeah, go ahead. Slide 5, Ms. Grant.
Yes, slide 5. Yes.
Okay.
The one with the U.S. stats by the Surgeon General. I think it's really important to always note that New York is its own ecosystem. And so because New York is its own ecosystem, we have to, have a more holistic approach and a more dynamic, if you will, approach to this issue. So where you see the results from the United States, that the time 7 to the postpartum death rate is actually overall lower, and it's more during pregnancy. We know that in New York, to the tune of 56%, more women are dying after they give birth. So it's important to note that. And just to piggyback off of Dr. Wilcox's commentary, when we use the rate of pregnancy related as 5 to 1, I think it's also important to put in those pregnancy associated death. We don't want to leave any soul behind in this work. And so, the current rate at the last statistic was what the Brooklyn Borough president aptly talked about at 9.4 higher. And so I really feel like that is the holistic number that we need to be looking at as we fight this crisis. We also know, just to piggyback more off what Dr. Wilcox said, in the top cause of pregnancy-associated death is mental health, to the tune of 18% out of the pregnancy-associated stats, with 75% of those lives being ended in suicide, and 25 with overdose. And so we need to be doing more around this issue. Because we don't want a woman to get through a pregnancy and then say, well, my God, after what happened to me, I wish I was dead. And then after the pregnancy, not have the resources, not have the mental health issue, mental health help during the pregnancy to navigate not only any pre-gestational or gestational condition that came about, but also the social issues that she may have to navigate as well. So it is really, really important that we look at this holistically. And to your question, which was a big question, I want to talk a little bit about history, because we have to acknowledge in these conversations that we don't get here by accident. This is historical. It should be no surprise to anybody that Haitian women, Mexican women, and Dominican women are the top 3. Why? Because you have what I call the quadrangle. They're women, they're of color or Black, they're immigrant, and they have a language barrier. So what does this mean for them? In the context of this, what are we looking at? What do these women need? And are we being honest and saying these women are more targeted? What happens when they walk into a facility in the space of what is perceived unknowingness about the historical context of this problem, who they appear and how they appear, their work-life balance and healthcare balance, and what are we doing not only as a hospital system, but in the hospital system, inner to outer and outer to inner, with our other resources, our community health, to really marry what we need to do to navigate this for these families. And so it's really, really important to look at this and not only just talk about the problem, but really unpack the why of the problem and really have these conversations and tell the truth about the why too.
Yes, if I can add, not much to say after Dr. Wilcox and Ms. Grant. And Ms. Grant, I cannot agree with more about the layers. I would say the layers of barriers that especially communities who have the barriers related to racism, structural and immediate interpersonal, and adding the immigrant status and language. The only thing I'd like to add, and again, I want to thank all of my co-panelists, Dr. Afable, our Brooklyn Borough president, and thank you for all the work that everybody is doing. Only thing I want to add related to the trends and that the medical conditions that we see are contributing, especially cardiovascular disease, it is also just a reflection of where we are community-wise as it relates to health. So it's when I look at the data from the most recent report that Dr. Wilcox shared, you also see the increased risk among those that had pre-pregnancy diabetes, hypertension, and chronic. So if they had barriers to care before, if they had poor relations with health centers for various reasons, if they were not able to access medications previously, if all the social barriers and stressors were contributing, now they're entering the system during pregnancy. And then as we know, pregnancy is like a vital sign of insult. So whatever was lingering before, it's going to only show itself more during pregnancy. So, and every one of the conditions, we can list both the medical contribution, the healthcare related contribution, including at the level of the practitioners, to the social and the barriers, and which is why it really takes a village on all layers to be able to contribute, and looking before, in between, and after pregnancy, if we really want to see the long-term impact and change that we're all working towards.
You already answered my third question, Dr. Pardo. But no, this is all excellent. And I think it's going to inform my last two questions. But before we get there, I wanted to give both Ms. Grant and Ms. Hall an opportunity to describe what they do specifically and what the roles of the midwives and doulas are in addressing this crisis. And at what time, so, I will say there is a lot of emphasis these days from the funding realm, because I am a researcher, on really trying to evaluate the role of midwives, doulas, and community health workers in providing and supporting maternal care. So if you both can comment on what are the distinctions between the two, because a lot of times they're sort of used interchangeably. And I think it would be beneficial for the audience to know, what are the different sort of capacities of each type of for midwives and for doulas, how they might be different from community health workers, and how do they engage the woman considering this continuum of her pregnancy, the different time points. So maybe we'll have, because we haven't heard from Ms. Grant yet, so let's hear from Ms. Helena Grant.
Who keeps calling? Okay, so since I'm not married to Ms. Grant, my name is Cheryl Hall.
Oh, sorry, Miss Cheryl Hall, yes.
Okay, so I think it's very, very important that we differentiate between the role of a midwife and the role of a doula. A midwife, I would say, she's working very closely with within the clinical world. In the doulas are working in the social world. They're providing social support. So I want to make sure as everyone begins to talk about this, we really, really differentiate between the midwife, who I believe is up here, and the doulas who are providing support to all providers. So that's the difference. For us, we're concerned, we think, doulas play a really important role in the total outcomes. We're providing prenatal, we're providing birth support, and we're providing postpartum. So I just wanted to make that difference, and I'd let Ms. Grant say what a midwife is, or what you guys do. And I will tell you one thing I know. I was delivered by a midwife. So would you take over that?
So I'm first going to say I'm grateful to you for switching up the question, because this is a question that is not often discussed, and it really deeply needs to be. So midwives in the state of New York that are licensed are certified nurse midwives or certified midwives. We are educated usually in the realm of nursing or some sort of other science, and if not, some sort of other baccalaureate degree, where then some sciences have to then be tacked on to be able to enter into a midwifery education program. All midwifery education programs in the state of New York are master's level. So a midwife in the state of New York has about 6 years or more of education to be able to serve clients in her role. There are many different doula programs. I know ones that are, 2 segments of a couple of hours for a weekend. And there are ones that can go on for a week or 2. But the roles are very specifically different because the midwives are grounded in midwifery care. That is the art of it, and also medical care. That is the science of that we connect to. 80% of all midwives in New York City, New York State, and in the United States of America actually work within hospital centers. And the other 20% are in private practices that serve women and families in the home. As far as the midwifery model of care goes, as our Brooklyn Borough president talked about, it is a shared decision-making model that goes into a lot of options, where the first pass of what happens to the client is what the client wants to do. It is not a patriarchal model. We're not the experts. We don't know what this person has going on in their life or in their house. And as I've been quick to say, even as a Black woman, I don't know, and when I get called on, I don't know about every type of Black woman, right? So I'm very careful about folks using this word cultural competency. We need to be using words like cultural humility, because it really keeps you humble in your knowingness. And so under this midwifery model of care, I can tell you all a bit about what we do as at Woodhall. We work with a fabulous cadre of physicians and nurses, and we follow this continuity model of care. Dr. Affable put up a slide 3, talked about the different other industrialized nations that the United States of America likes to compare itself with. And you look at every other country on that list, midwives are the leaders in the birthing room, all of them. Every country on that list that has the lowest maternal mortality and morbidity rate, midwives attend the birth to upwards of 50 to 75% of the births. And so we do understand that we are in New York City. We do understand there are epigenetics that go into why some of our women come to the pregnancy with pre-gestational conditions, or they develop gestational conditions due to historical consequences, due to the social determinants of health, due to medical comorbidities, and we understand that. And so we have a saying here that every woman deserves the touch of a midwife. So we work collaboratively with our physician colleagues on that. A person who comes to Woodhall for their care, she may get a physician or get a midwife. We try to keep, we don't want our patients to be seeing a different person every time. There is no way anybody's going to develop a relationship with a patient if you're bouncing the patient from pillar to pole, and every time they come into your practice, they're seeing a new face. Pregnant people want to develop a relationship. They don't want to explain their whole life story or why they didn't come to an appointment to a new person every time. If there is a condition that develops, and they do, we co-manage the patient. If the patient is really attached to her midwife and completely enamored, she can see the physician for one visit, go back to the midwife, and we just work together. So it is the marrying or synergy, the best of both worlds. And if the patient has really gotten to this thing where, oh my God, I'm high risk, we tell our patients, high risk for the pregnancy does not mean we are going to put a high risk label on you for your birth. All of our patients return to the midwife's care when they are giving birth. So the midwives at Wood Hall attend 95% of all the vaginal births. And so this type of system that we've set up, we feel like is very holistic. It is a model system that is based upon, I hate to say this, the European model, but I would dare say it's based upon an ancient system of what collaborative relationships, not just with the people you work with, but with the community, because we do care for a large Hispanic Latinx population, and they know what a partera is, they know what a comadrona is. And so, you know, we believe that patients don't know, and when they hear that, they're like, oh, this is not quite like it's in my country, but it's similar. The energy is similar. And so when I have a different energy with you, you're become an open vessel to me as a patient. I can communicate with you more. And so the education I'm offering you about what you need to do to stay healthy, you're going to be more receptive to, because we've developed a relationship.
Yeah, and that's such an excellent point, developing trust in a relationship, you know, and that is a common concern or issue that is raised in this space. I appreciate your point, Ms. Grant, about how the model of collaborative care and the model of supportive care is not unfamiliar to people that come from outside the United States. This is a model that we all grew up, you know, our parents grew up with, you know, in Latin America or in, you know, Asia, in other parts of the world. The idea of a community health worker or a supportive care provider is not new. And I don't know why we have not adopted that fully yet in the United States, which is, you know, we could talk about that a little later. But I want to follow up on Ms. Hall's discussion about doulas. Can you tell, to what extent, in your opinion, Ms. Hall, have women that we want to, that, you know, that we do consider, you know, high risk from both a social and medical standpoint, to what extent are they engaging with doulas? Are they looking for doulas? I know that Dr. Pardo recently had hosted an event at Life of Hope talking about doulas among the Haitian origin community. Do they accept doulas here in the same way? So I guess that's my question.
Okay, so I think that, you know, we've been in the doula world, I think since 2014, through Healthy Women, Healthy Futures funding. And most recently, we have received funding from two other foundations. And in addition to that, to the community initiative that was announced by the mayor. And, you know, I think we recommend that doula care should begin as early as the second trimester. That because it gives clients an opportunity to become more confident with building a care team and determine what they expect out of their labor and delivery. So we can do that. Doulas are good at sharing that type of information. This also helps to combat any medical concerns clients may have early on. And again, we inform our doulas that they're not to give medical advice, but they can help prepare questions that the client can ask on their follow-up visits. The current scope of the community-based doulas that our organization provides for services to high-risk clients begins in the third trimester, which has been proven effective and addressing the medical needs of the clients while they're pregnant, but also in providing that level of comfort and support, which gives them confidence in seeking their prenatal care. It's important that we get these moms into prenatal care as early as possible. Again, within our community, we're concerned about two things, and I will bring it up. It's immigration status and lack of access and inability to be able to have health care. So I think those are things that we have to address as soon as possible. For as early as we can be available to them. We support clients in the prenatal period, during labor, delivery, and also in much needed postpartum period. And then when we talk about postpartum periods, I know we have begun the discussion about extending postpartum for a year. And I can speak to a pilot we're doing, but we have begun working with community health, the doulas, turning those clients over to community health workers. But I'll discuss that at another time. We find providing doula care early on in pregnancy increases the support that a client gets and contributes to better outcomes for birthing person and baby, and increases their satisfaction during birth. There are instances where doulas are assigned the day before a birth or even at the time of labor. While the situation is not ideal, doulas are trained to support and listen to their clients in those experiences. So again, a doula is there for support of these moms before they get to you guys and after they leave you, and prepare them to come back to you, which is so important for postpartum care. Thank you.
Dr. Pardo, do you have anything to add in terms of engagement between the maternal population and doulas and our midwives?
Sure. Actually, first, I want to make sure I acknowledge Ms. Hall, we have, and Dr. Blackwell, we have a community advisory board. And I will say at my institution, when we started the work to address the disparities affecting our community, the care and disparities within our institution, the first thing we said we have to do is to connect with our community to hear directly from them, the word on the street and what's going on, and to hear how we can improve, not just one time, but continuously what we were doing. And I found, and just to, to admit this, that because a lot of what we were doing is going to be a change of culture, right? Change of culture within our institutions, within the obstetric units, among everybody, from nursing to providers to everybody within. And I found that bringing in the community voice directly into that, so we can hear about what's going on, was really, really probably the most helpful and important step that we took to start to institute change. And one of the things that we did was from that community advisory board is to develop a collaborative relationship with many of our community organizations that have doula programs, such as Korean Women's Health Association, BPN, you're just talking about many of the others, because we cannot do it all on our own. And we know that this partnership was essential, and not only to refer patients early, but to help to integrate within our system. So to create a system, continuously hear feedback from doulas, from patients, and continuously work to improve it. The one thing I would like to add as it relates to especially working with our immigrant communities, and you mentioned with the panel that we did, and we actually decided to do that panel, which is called in Creole, Sak Doula, which means, what is a doula? Because that's the first thing we often hear from our Haitian patients or clients when we talk about doulas. And I will say, since we've started university screening our patients for needs, the #1 request is for a doula overall, and not even about the social, aspects or any request for services. The #1 request that we do receive are doulas, but we notice among certain communities, there is a gap in understanding or comfort as it relates to doula. And what's interesting is when we started that panel, and it was like a discussion back and forth of different terms in Creole because in Haiti, there are different persons in the community who provide support during pregnancy. And so we had these, 3 or 4 different terms for people who provide support in maternal delivery in Haiti, and kind of arguing which one is most applicable to doulas. So it's really important that we go even deeper to any system level or community level intervention that we're doing, and helping to translate it for certain communities. It may not even be translate figuratively as it relates to language, but to make sure that different communities have an understanding and comfort. We find that in certain communities, when you mention different services, there is an apprehension. When you mention things like doulas, there is an apprehension. And it really takes time and engagement to see the benefit and to really be able to engage in services. For example, we see many who have many misconceptions about participating in WIC, food stamps, different services. So taking all the work that is being done at city and state level and translating that for our community so that we can really make sure we engage is extremely important. And we cannot do that without our partners like Ms. Hall and many others that are working in the community.
Excellent. Thank you, Dr. Pardo. And sort of the highlighting really how much work we need to do in terms of doing, ensuring that our research and our questions and our interventions are more precise and, target sort of the specific needs of different populations, and the need to go sort of dig deeper into what the issues are. And I want Dr. Wilcox, she's been waiting in so patiently. She's been, and I think she wanted to comment on something earlier that Ms. Hall said. So go ahead, Dr. Wilcox.
Oh, well, I just wanted to talk about what everyone has been contributing, toward. I just want to say what we started out saying, what a complex problem this is, and asking the question to ourselves, why does this disparity still exist, even when we are making positive forward movement toward decreasing both severe maternal morbidity and maternal mortality? And the answer is because this is a highly complex problem that requires many, many different solutions all at the same time. And so, of course, Ms. Hall and I work together, right? We've been, as well as Dr. Pardo, everyone on this panel, I've had a really great working relationship with. Doulas are an important part of the solution. What Ms. Grant said earlier, and I want you all to be aware that at New York City Health and Hospitals, we are the largest employer of midwives in New York City. We are proud of that fact. And in fact, we have an active study going on with one of, I think, the audience members, Dr. Niles, who's in the audience, because I saw a comment from her earlier, looking at all of our facilities, because there are 3 that do not have significant midwifery practices, to increase that and see how we can synergize ourselves as a system to really bring midwifery to everyone. We have something called the maternal home, which has been tried in different parts of the country, and which we launched as a hospital system back in 2018 as a City Hall initiative, which has been wildly successful and which we are looking to expand. Our maternal home is composed of social workers and care coordinators. And what they do is assess every patient and help us to screen all of our patients. And someone asked the question earlier, what is high risk? Well, you're absolutely right that there might be many different definitions to that. There might be risk associated with social needs from social determinants of health. There might be risk, affiliated with clinical issues and or with behavioral health concerns. And so really what the maternal home does is takes all takers and will assign a risk tier to them. And from that, make referrals as well as be a companion throughout the prenatal period to help with care navigation and any other questions or support the patient might need. And we've made a tremendous, in the 2 completed years that the maternal home has been in existence, they have made over 8,000 referrals, over almost 2,000 referrals. I know it's over 1,500 to community-based organizations for care, and a large proportion of that is also for doula services. The Commonwealth report, and I don't know if you were going to say this, Dr. Affable, but they just released a new report that showed out of all of the developed nations, similar to what you're showing right there on the screen, we spend the absolute least amount on women's health, period. So therefore, if we're not having healthy patients coming into the stage of pregnancy, can we really expect what, the outcomes are as expected, right? We as a society have to really get our hands around the fact that women and children are important, and we need to spend healthcare dollars as well as other dollars, green spaces, healthy foods, exercise, good schools, et cetera, the list goes on, in order to make sure that our population is as healthy as possible prior to entering the stage of pregnancy so that we have healthy outcomes. So thank you for giving me the time for that.
Thank you.
And Amy, I just think
Go ahead, Ms. Off, go ahead.
we have everyone at the table. You have the hospitals, you have the providers, and the community-based organizations. The doulas alone cannot solve the problem. The doctors alone cannot solve the problem. I think we have to really think of a holistic way of working together and making sure that we keep the focus on the patient. And that's what we have to do. We'd have to tweak programs, we'd have to change programs, but you have to have everyone working together.
Dr. Wilcox wanted to say something in response again.
No, I actually was looking for my little clapping hands.
Okay. But so then, yes, I want to follow up on that because it has to be holistic. But New York City is described as both the social service sector and the medical care or medical system is described as fragmented. Dr. Camille Claire, who I don't know if she's here, but anyway, she recently, and I didn't read this, but she recently sent me a study that was, I think, 2006. It was a study that looked at health systems in New York City, and the author characterized New York City as having a health system that is separate and equal. Okay, and so 2022, we still have the same system. So based on what everybody is saying here, how can we work together? What structures are, again, and I was going to sort of comment on a 2020 study that looked at neighborhood level factors as contributors to severe maternal morbidity. And it looked at sort of factors such as the concentration of poor Black individuals in a community, hospital delivery site, et cetera. That study found that only 35% of variation in severe maternal morbidity is explained by hospital delivery site. So if the problem stems from outside the hospital, what systems and structures beyond funding, right? Beyond funding, what structures do we need in place to deliver holistic care and sort of build on everything that you all have been talking about, elevating the importance of collaborative care and perhaps even care led by midwives and that respect the patient and give priority to supportive care. So again, so this is sort of a question that gets to, we talked about sort of some of the downstream determinants of health. What are the medical risk factors for severe maternal morbid event or death? But what can we do as a society at a system level to facilitate everything that has been raised here by the panelists?
I think we have to look at a bunch of different issues. There are several factors that contribute to this. Access to healthcare in the US is primarily through if you had health insurance, whether you get public or private. However, conservative estimates place the number of uninsured as 40 to 45 million. So those are some of the people who are trickling into your hospitals. A critical question then becomes, who are the uninsured? They tend to be largely people of color, poor, and immigrants. There is part of our issue The cost of health insurance is prohibitive for those who do not obtain it through employment or who are eligible for public insurance. The lack of sufficient, carefully planned, high-quality health services, strategically placed and offered at lower cost throughout the poor and immigrant communities. Women of color work at the bottom of the pay scale, creating a systematic disenfranchisement in building foundational wealth in families. The issue of pay equity impacts food security, housing, and many Black and brown families lead to an increase in health issues such as hypertension and diabetes. So, it's just not a woman showing up, getting pregnant. There's so many issues in this woman before she even walks through a door. And how are we going to address that? We have to understand that. And it's happening, unfortunately, in the Black and brown communities. So how do we solve it? We have a lot of work to do.
Dr. Pardo.
Go ahead.
Yeah.
And to add to that, there's a lot of work to do, but what I hope to see, in which I know we are moving towards more and more, because of what people on this panel are doing, is where we do all of these in an ecosystem, almost, in that there is a lot of work to do within hospitals related to interpersonal care, related to diversity and options with providers and midwifery, related to access within the community, barriers to care within the community, doulas, community health workers, interventions. And one thing I always notice is that many things are being done siloed. So, for example, one group is unaware of what is happening outside and vice versa. So if we talk about our practitioners within the hospitals, I find a lot of oftentimes not as aware of what's the changes, the opportunities that are available, education, up-to-date education, and working together on what is happening policy-wise and within the community, and vice versa, for community to know about the advances made within hospitals, within hospital systems, and work coming collectively as we continue to advance what we're doing separately in parallel, but creating an ecosystem so that we can work synergistically. So a lot of things happening in parallel, and I hope we continue to move where we're creating these ecosystems in our communities to advance this work collectively.
Ms. Grant.
So I'm going to say the big two for me about what needs to change is, I don't need to get into what Ms. Hall said because I had some notes here, but she said it all. So we can just drop the mic because she just talked about everything that happens outside. But inside the hospital space, we have to be accountable to one another as providers and nursing staff. And, like I say, my calling in this space is to perpetually sit in a sacrifice seat, meaning that anything that happens that was not right, that the patient says they didn't like, that, went wrong with the team, that I'm gonna, in a leadership position, lead and say, well, I'm part of the responsibility for that, and let's fix that. And so I don't think there are a lot of conversations that are really happening that are transparent, that sometimes bother people, but people have to get comfortable with being uncomfortable to talk about these issues. Because again, although these issues are medical, I dare say they're psychological, social, cultural, and even maybe spiritual at times. And so when we unpack this multi-level factor and we start dealing with people's epigenetics and the stress and their comorbidities that they bring in the space, what are we doing inside the hospital? Because the etymology of the word hospital actually means hotel of healing. I say that all the time. What are we doing in the hospital to make sure that we ensure that it is a healing space for the people that enter it? So that's my first thing. Who are the people who are going to address every single thing all the time so that we improve? Are we giving respectful care? Are we giving trauma-informed care? And when we're not, who is going to be responsible to be the change agent in the space to do something about it? So that's my number one. My number two is, are we being transparent about what we have to offer in these spaces and what our statistics are? The statistics are part of, the hospital or part of the corporation, but, people are accessing this. So when we're having these community board discussions, are we saying to them, well, hey, our C-section rate is this. We don't do VBACs, only these people do them. Our VBAC rate is this. Are we giving our Black and Brown clients the level of information that our white serving people know to go on the internet to go see, or are we hiding it from them? I think these are the deeper conversations that we need to have. We're used to saying we're the community, the community hospital for this particular area, but are you really being accountable for what's going on in the hospital space and sharing that transparently with clients? Because maybe if you did and you really don't have what's going on that's proper and that's right and exact, they might make a better choice. I always say the litmus test is, are people who work in your facility utilizing your services? And would you utilize your services or have someone in your family utilize your services? And if you cannot definitively say yes to those questions, there are some things you need to change.
I see comments that you are so on point, Ms. Grant, and everybody appreciated. We have to be comfortable with the uncomfortable, and that's so true. And sometimes that's a difficult thing to do. We're actually at the end of the webinar, but I want to give Dr. Tanya Blackwell an opportunity to provide questions, because so much has been said today, and I always want someone objective to sort of view this, because I have my own biases as well, and I want to give her an opportunity to ask questions or maybe make commentaries on what has been said. As Dr. Pardo mentioned, Dr. Blackwell is part of this SUNY Women's Community Advisory Board, and work closely with Dr. Pardo, as well as she is assistant professor in the School of Public Health. So, a lot of her work is directly relevant and will feed some of the research that we're doing at the school. So, Dr. Blackwell.
Thank you. I'd first like to just give a huge thank you to all the panelists. Everyone had, such great and profound information to share, and sharing your experiences and your intellectual property. There are a lot of huge takeaways, and I have pages and pages of notes, so I won't, bore you all with me trying to go through them, but you can imagine my brain is racing on so much that has been said. But what has stood out is the fact that we cannot do this alone, right? The healthcare system cannot do it alone. Yes, we have multiple upon multiple of factors involved. I heard people speak about the social ecological model and the many different arms, like an octopus, that needs to focus on so many things. I think one issue about access to care. Yeah, we have folks who are insured versus those who are uninsured, but it sounds like to me from this conversation, access to care should also mean access to doulas and midwives as much as a clinician. We cannot do it alone. And one of the things that we focus on at the Arthur Ashe Institute is making sure that community voices are at the table with decision makers and clinicians for providing care, addressing those social determinants of health. I hear there was one comment that women's lived experiences aren't being heard. We do hear that a lot, that, there's this strong Black woman syndrome, and when a woman is expressing some concerns about her care, it's just ignored or just not taken into consideration. trust. We're huge on building trust. And I think this pandemic that we're trying to bring ourselves from sort of highlighted how much there is such a mistrust in our medical institutions. And I believe it was Helena that said pregnant women want to build a relationship. I mean, pregnant women in their conditions and the hormones and emotions flying high, of course they want to build a relationship. So I think one of the questions was, what are some of those barriers within the Central Brooklyn system that cause it so that women don't get to see that continuity of care from one particular OBGYN? How come it has to change and they see different faces and that barrier to them developing relationships? But particular questions, what are the healthcare facility factors? And some of you spoke on some of this, like the administration of care. What are those factors within the facility for Black patients versus white patients receiving differential care? I think I offer the panelists to respond to that, but I like to respond to that too. Sometimes from the top down is funding. Unfortunately, our facilities in Central Brooklyn aren't supported, funding wise as other institutions are. And so from a policy level, there's so much attention that needs to happen there. On the ground with the pregnant women themselves, I think Cheryl Hall pointed out, and I appreciate you making the distinction between midwives and doulas, and where midwives focus on that more clinical side, but doulas focus on the social world, the clinical world versus the social world. And one thing I stand firmly by is that we cannot do it in these silos. We cannot continue to operate in silos, or if there is this competitive edge to the healthcare system, it needs to be done away with. But there are what studies or projects would have the highest impact on showing the need for doulas and midwives? Are there any studies to our knowledge that makes the case or the argument for utilizing doulas and midwives? I know Mayor Adams has started an initiative, but do we have any empirical data to make the case? I know we all have our anecdotal and lived experiences, but are there research studies that one could pay attention to for the argument of doulas? And I'm sure there are. I think Mayori asked that question, but there are a lot of studies happening. I think another important question when we talked about historical factors and historical context, I think without paying attention to race and racism and discrimination and the implicit bias, I heard that, and some biases that we all carry, or some cultural stigmas that we project not knowingly, that we need to address and face. So I think this conversation is the beginning of a long set of conversations. Sounds like we need a system change. Well, I know that we need a system change, but as Christina says, we need a culture change. We need a change in culture, and it's not always about cultural competency, but humility. I think Helena said something else very profound, in that it's about what the patient wants. And there's a contradiction there when patients' desires are not being valued or respected, but making the patient the expert. That's one thing, also at the Institute, when we develop interventions, it's about the community and what the community recognize as their needs. I always say the community members are the experts of their own lives. We may be the experts, in our specialty, but they're the experts in their own lives and lived experience. So having community at the table also is huge. And I feel it does not solve the problem when we look at only correcting things in the clinical space. Someone did say that. And so I'm hoping to see a more holistic, patient-centered approach focusing on mental care. I know that we're doing some work looking at discrimination. If we can't be, you know, like you said, we have to be comfortable being uncomfortable and talking about such things. I know that we're at the, you know, the forefront of looking at things like discrimination and racism in healthcare. And so I think someone asked, when those types of instances occur in our hospitals, is there a system for tracking that and for patients to report that? And I'm glad you asked, because we're actually working on something of that nature now with the Brooklyn Health Equity Index to capture those very things. And so once we do that, we can begin to start unpacking some of the many issues that we're seeing highlighted in Central Brooklyn pregnant women. And so I'll pause for a moment to see if anyone had a response to any of that. But there were other questions. I think people asked about addressing stillbirth and the rate of stillbirth being so high and what's being done about that. So I'll let one of our clinical professionals respond to that comment about
Excellent, Tanya, and thank you for tying it all together and making sure we're addressing the audience's questions and comments. I just want to be mindful of everybody's time. The webinar did end at 1:30, and so I know everybody on this panel, you know, based on the introductions and your bios, we're all super busy and you have a lot of things to do. But I just want to give an opportunity for one final comment from each one. I want to just thank you, you know, give like a sincere, you know, appreciation to everybody for coming on this panel and joining it and committing to it. You know, it really, I learned a lot about, you know, everyone on this panel is not just talking the talk, they're walking the walk, right? And so, and I appreciate that. I think a common theme is collaboration, ecosystems, trying and holistic approach to the way we're approaching care. And there are a lot of lessons learned from outside the United States that we can take, not just only to Brooklyn, but perhaps New York City and nationwide. So final comments from the panelists? No?
I would just like to, yes, no, I'll definitely say thank you so much for inviting me. This was certainly an informative discussion, and I really appreciated the you know, the input that all of us had to make. In terms of comments that were made about collaboration, I give kudos to Borough President Reynoso and thanks, because the fact that from his office he wants to focus on this means that strides will be made. And just the fact that this is, you know, pretty much the first step that we've taken, but that it will include all voices in the discussion for solving, as we said, this really complex and devastating problem of Black maternal mortality and morbidity is means that we're going to get some things done and more successes. So thank you.
Thank you. Anyone else? Final comments? Everyone said enough. Well, anyway, I appreciate everybody's passion and sharing their insights and their lived experiences. And this is, as all of us have said, this is just the beginning of the discussion and conversation. And I want to acknowledge the Brooklyn Borough President's Office staff, Manyuk Yu, Stephanie Guzman, who also helped us coordinate the panel. This was a request from their office because of, as we heard earlier, Mr. Reynoso's priority agenda items, which is one. Obviously, he had mentioned that maternal health is his priority, and I'm grateful that he is prioritizing collaborative care. So I look forward to, you know, what Brooklyn can do in this, how Brooklyn can help solve this this enduring sort of challenge that we've had. So thank you, everybody. I have my email is here. If anyone wants copies of the presentation, please feel free to email me or has any follow-up questions. feel free to email me. Otherwise, again, thank you so much. Much gratitude to all the panelists for dedicating time to this important discussion. And I'm sure I'll be seeing you very soon, working together. Thank you so much.